My name is Alec Patterson. I'm a past president of the International Society for Heart and Lung Transplantation. The society has embarked on a project to interview pioneers in transplantation. I'm joined today by Shaf Khashabji, who's the chief of the thoracic surgery program and lung transplant program at the University of Toronto, and we're here to interview Dr. Joel Cooper, who's currently the chief of thoracic surgery at the University of Pennsylvania and a pioneer in lung transplantation. All three of us have worked together in the past while we were at various stages of our career in Toronto. This is kind of like a reunion. And Joel, to look at your remarkable career, you went to college, started your medical training, did your surgical residency all at Harvard, at Massachusetts General Hospital, terrific institution, but what is it that kept you there for all of that training?
Well, for whatever reason, I knew I wanted to be a surgeon. Actually, I thought I was going to be a neurosurgeon. A year of research in a neurosurgical laboratory at Children's Hospital after my first year of medical school cured me of that notion, when I used to make rounds with a very famous surgeon, Donald Mattson, and see those kids with various tumors of the brain. I got that notion out of my mind, but I love surgery. And I suspect, like many of us, it was experience during residency years that made me interested in doing thoracic surgery. Hermes Grillo, wonderful mentor and surgeon. David Skinner, chief resident, got me very interested in thoracic surgery. When I was an intern, I got assigned to the respiratory intensive care unit. It was a different era. There were 3 such units in North America. One was in Toronto. Barry Fairley ran it. Henning Pontoppidan ran that one. And I think Peter Safar ran one in Pittsburgh. The sum total of people on a ventilator in the entire Massachusetts General Hospital was 5 beds, carved out of a few private rooms with walls broken down. And that was the entire respiratory unit of the hospital. And I was an intern, and I was ostensibly in charge of that. And that's where I think I got particularly interested in respiratory care, seeing some great anesthesiologists and pulmonologists, and stimulated by Dr. Grillo and Dr. Skinner. So it was a different era, but it did turn out to be very relevant to my ultimately wanting to do something involved with pulmonary surgery and pulmonary physiology.
You had some interesting, I suppose they weren't translational research experiences perhaps, but some interesting research experiences in Boston. How did that evolve?
Serendipity. When I was a second-year resident, it was in the early days of open heart surgery. I was known as the man in the groin. My job was to prepare the femoral vessels, the femoral artery and the vein, which were then used as the cannulation sites in the early days of open heart surgery. And I was what we now call an R2, and that was my assignment. There was an old disc oxygenator. There was a senior resident as well. Valve surgery had a 30% mortality. The pump was primed with 5 units of freshly drawn warm blood from relatives and donors who came in that morning. There was no typing for what we now know is hepatitis, let alone other diseases. It was blood group matched. I'm sure I'm not the only one who stuck myself with a needle. We all stick ourselves with needles, and a tremendous number of residents, including myself, got hepatitis. I was yellow as grapefruit. I had a bilirubin, I think, of 30. And so I was out for a month, having stuck myself, presumably with a needle, with all this. And Dr. Grillo, Hermes, was the director of the residency training program. And when I recovered, he said, you really shouldn't go back to this every other night, every other weekend arduous schedule, because you really need some time to recover. And he assigned me to a month in pathology. Again, serendipity, but had a long-lasting impact on my career. And he had a great interest in surgery of the airway. Particularly, he wanted to know what was causing damage to the trachea in people who had been on ventilators. And so he said, why don't you sort of look into that when you're down in the pathology lab? And I did. And working with Hermes, doing studies, I arranged that everybody who died in the hospital while receiving ventilatory assistance with an endotracheal tube or a tracheostomy tube would have the tube left in place. Usually it was taken out and the body was sent down for autopsies, which then were far more common than they are today. And so I began trying to figure out the relationship between the tube and the injury, and Dr. Grillo thought maybe it was the ethylene oxide used to sterilize the cuffs then used, or it was the tip of the tube that was gouging the airway. And it soon became evident that the cuff was the problem, and that's what started my interest in the airway and working with Hermes and developing an animal model. Realized that the old-fashioned high-pressure cuffs were like stiff as a golf ball, were just causing injury to the airway, which ultimately, weeks later, when the trach tube was no longer there, would narrow down. You get a scar and a stenosis. It was very common in those days. And an awful lot of people on ventilators didn't actually survive the experience in those days. So again, it was just serendipitous and really under Dr. Grillo's mentorship and with some others, I got interested in thoracic surgery. David Skinner had been to England to work with Ronald Belsey, as had some others, and they arranged for me to go to England for a year. Before I went to England, Dr. Grillo didn't want me to seem like a complete ignoramus, and he gave me a very prized rotation at the Middlesex County Sanatorium. It was one of the last 2 TB SANs still open. There had been 25 in the TB era. People there had cavitary disease which hadn't been cured, or sometimes there was open negative cavities, and we'd operate twice a week. Gordon Scannell, a thoracic surgeon from the Mass General, would come out and assist, and I lived out at the TB SAN there for 3 months. It was a wonderful experience. Dr. Grillo gave me that rotation as an R4. It was a very prized senior rotation, so that when I went to England as a senior registrar, I'd had at least some experience. And so it was that combination, wonderful mentors, great examples, interest in physiology, chance to work on the airway, that sort of really changed my whole life.
And how is it, having trained at the Massachusetts General Hospital, a premier institution in the United States, terrific cardiac program, terrific thoracic program, how is it that you then took as your first faculty job, a job not only in a different city, but a different country? Like, why Toronto?
Combination again. First of all, my dad was from Toronto. I have more relatives in Toronto than the city, one of 9 children. Actually was born very close to where the Toronto General Hospital is, and as a kid we used to go up there, and his parents lived on Grange Avenue downtown. So that was a factor, but the real factor was I saw in England a regional center for thoracic surgery. That regionalization, plus the long waiting lists, led to a large volume of thoracic surgery referred in. We did a great deal. There were long waiting lists, and each week we'd go in England to Ms. Thomas's office. She was the secretary to Mr. Belsey, and we decided, what do we want to do the next week? Well, let's do 6 lobectomies and 3 Zenkers, and let's do a couple colon interpositions for strictures of the lower esophagus. It was fantastic. But I did see this focus on thoracic surgery, which didn't exist yet in the United States. Dr. Grillo did gallbladders, colons, thyroids, and lung surgery. It really hadn't developed yet for people to do specialized training in general thoracic surgery, which was sort of waning, and cardiac was coming up. And I love thoracic surgery. Dr. Grillo introduced me to his very good friend, Griff Pearson, in Atlantic City when the American College of Surgeons used to meet there. In fact, I think we went out fishing for the day, which is another factor. As you know, I love to go fishing. I talk about it more than I do it. So it was a combination of being able to go to a place, work with Dr. Pearson, where the approach to thoracic surgery was focused, sort of regionalized, where I saw that they were 10 years ahead of the kind of experience that I'd be able to get at the Mass General. I was offered a position there, and I pointed out that if I did stay, I would only want to do general thoracic surgery, that I would give away the gallbladders, the colons, and the thyroids. That wasn't the way things were done there. And so when the opportunity opened itself up for Toronto, I went there thinking we'd stay a couple years. We had 2 young kids at the time. I thought by the time they'd go to first grade, we'd probably come back to the States. But it's such, as you know, a wonderful city. I don't have to tell the 2 of you who have worked with Griff Pearson what a Pied Piper he was.
What did you think of the environment when you arrived at Toronto General Hospital? Because you were a big part not only of coming there, but of shaping that institution.
Well, I didn't feel that way when I came there. I've often told the story of my first month in Toronto, a city where I didn't train, an institution in a city where I wasn't known. And in that first month, because of Griff Pearson and the kind of person that he was, as you know, who was so generous in his support, in that month I did a tracheal resection, an esophagogastrectomy, a pneumonectomy, and a lobectomy. Now, who starts their career, at least in those days, that way? That's the kind of environment. It was very exciting. The diversity of thoracic surgery, the volume of thoracic surgery. We used to be, I think it was called on A East. It doesn't exist as a ward anymore, and that was a thoracic unit. And Griff, you know, had started that. I think Griff started that with the support of Fred Kurgan in about I came in 1972, and I believe Griff started that unit 58 to 62, somewhere in there. And he too, as you know, had been over and studied with Ronald Belsey. And in those days, going to England, if you were in the States, was the way you learned thoracic surgery. Mark Aringer, David Skinner, myself.
I think they got permission to start that separate division in 1967, a short time before you arrived. You might just comment.
No, you are absolutely right. You're right.
Just to comment, if you would, on the. We know everybody knows about Dr. Pearson, but who else were in the environment? How did the environment work? I mean, remember those huge Friday morning clinics, which are terrific teaching experiences. So who else? And I think we're going to talk subsequently about some of the experimental work that grew out of that. But you might comment on the environment.
Well, those Friday morning clinics were actually something that Griff and I both learned from Belsey in England. We had that sort of a model where we had these large follow-up clinics. Griff, as you know, was a wonderful surgeon. The environment, the hospital, the healthcare establishment. I've often said that, you can find faults with the U.S. system, you could find some faults with the Canadian system, but it was a wonderful system. The doctors worked cooperatively with the government. Okay, you didn't earn the kind of money that maybe you had made in the States, but also in those days, people didn't tell you who you could admit and when to discharge them, and probably Canada is more immune to that than the present time. And Griff set a stimulating environment, but he in turn stood on the shoulders of others. Fred Kurgan, James, famous thoracic surgeon there. I came up, Fred Kurgan interviewed me. I've often told the story about Dr. Mustard, Bob Mustard, who was chief of surgery and esophageal surgeon. Griff asked him, well, what do you think of that young man, after he'd interviewed me? And Dr. Mustard said to him, well, you know, I think he's okay. He'll be all right. But mind you, he'll probably be like a little sand in your shoe. Anybody who knows Griff
How right he
knows
was.
that Griff's been limping ever since. So I've always felt that what I learned in England is that the quality of surgical care that you deliver is better when you have a team, when you have resources. We had chest physiotherapists, we had dedicated anesthesiologists, we had a unit and a nursing unit and specialized training. And that's really, I think, was the model for Griff creating that environment. And you had an institution which was supportive. Probably the thing that I appreciate most in retrospect is the collegiality. The fact that we had a wonderful team, 5 thoracic surgeons at one time. We knew those were halcyon days. We knew that someday that would probably not persist, but everybody proud of each other's accomplishments. And again, I have to get back to Griff. He taught us how to play in the sandbox.
Tell us about that philosophy, because I remember coming onto the service as a young resident, and I saw some of that, and that was an exciting time where you were doing things that had never been done before, but you fed off each other. You used each other's talents, you know, in terms of research, like what Alec was doing, what Tom Todd was doing in critical care, what, you know, Griff's total curiosity and energy and enthusiasm. I think that is...
Yeah, and his selflessness, his excitement to see others do things, his support of others, his creating that kind of environment. We heard earlier today of the kind of environment that Dr. Shumway provided at Stanford, which was such fertile ground for the development of heart transplantation. And I feel that the environment in Toronto and that was provided to me, the support, and the willingness of people on the team to work together to be proud of each other's accomplishments. You know, part of that, I truly believe, was reflected in the economic arrangement. We were equal partners. The finances in those days, I know that Griff took a significant hit when I came because he had to maybe divide the financial pie a bit more. Didn't bother him at all. But we didn't have any economic competition, and you were valued, as both of you know. Whether you did teaching, you did research, you felt that you were part of a team.
Tell us about lung transplantation. Like, you know, at that time, it had never been done. It was not, had never been successful in the long term. And it was a very, very challenging problem. And I think one of the unique things that you have taught generations of your students is that sort of persistence, that you're going to find an answer. You can sort it out. Tell us about how you approach something like that when many had failed and you failed.
Yes. Well, I can summarize briefly, but again, there had been a tradition there. In fact, if you go back to that era, almost every thoracic surgeon you can think of at one time or another did some work or had some interest in transplantation, and Griff was one of those. And he, as you know, worked in the lab, and with Bob Stone and Mel Goldberg worked in the lab, and Manny Locher, the pulmonologist, I think, worked with him on tantalum bronchography. So number one, there was an existing lab, which made it easy for me to get into. And I had gotten interested in ECMO, artificial lungs for temporary support. That fit into my interest in respiratory care. When I came to Toronto, there was a ICU, one respiratory care unit for neurosurgical, general surgery, medicine, cardiology. Griff was one of the co-directors. I took over that position, so again, had some experience there. The very specifics of my involvement in lung transplantation was, number one, I was interested in the artificial lung for temporary support, and we had some successes in the team for putting people on ECMO for a period of time until hopefully their lungs would recover. And we had a few exciting successes. Bill Nellums, as you know, was a faculty member there, a contemporary of mine. He had gone off at Griff's encouragement to work with Charles Wildefeuer in Holland on lung transplantation, and came back and was eager to do a lung transplant. And I think, let's see, I came in 72, so I believe that it was 1978. Bill came back, I think maybe in about 74, that he organized a lung transplant on a victim of a house fire who'd been on a ventilator for 4 or 5 months. I had the ECMO interest, no transplant interest, really. Bill had the transplant interest, Griff had a transplant interest, and my role was to support the membrane oxygenator, which we did use on that individual. And he had short-term success, died about 18 days later when his bronchus separated. And what happened then was Bill and Tony Buck, the pulmonologist who was very involved, they were discouraged. I mean, that first week or so, it was so exciting, and they were on top of the world. We all were, because he survived. He got off the ventilator. We've got pictures of him outside with his trach in place, but not on a ventilator, with his bicycle there and his mother standing by. And then it was just, you can imagine when he died of the dehiscence of the bronchus, what it did. And that led to a lot of discouragement. That was about the 38th attempt in the world. And I don't know if you probably know the story, but what happened after that was not much for a year or so. And Griff came back from a trip to Marseille, where he had been. He'd been in France, and he had run across a surgeon from Rio, Oriane Lima, who wanted to do some work in airway surgery and had gone to France to do that, and was disappointed with the experience. Interestingly, if you were in Brazil then and wanted to be an academic professor, you had to have a PhD in addition to your surgical
I
training.
think it's still the case.
And remarkable. And Griff came back and said, I met this fellow, he'd like to do some work. Would you willing to take him in your lab? And I was working on ECMO. But he needs to get a PhD. I said, Griff, that's a great obligation to try to provide a project of sufficient depth and duration and importance to get someone their PhD. And I thought about it for a while, still wasn't thinking of lung transplant. And that's really what got me started. So he came, trying to come up with a project. We realized that when we had reviewed the literature, that healing of the airway anastomosis was really the Achilles heel, that the majority of people who, in fact all of them, who lived more than 14 days after transplant died because of or with airway problems. So I figured, well, he's not going to solve that one overnight. And working in the laboratory, Mel Goldberg, who had worked with Griff, worked in the laboratory. The two of you, obviously, subsequently very much involved in that same type of laboratory work there. And Oriane did the work. We designed experiments. Earlier today, you showed what was one of those serendipitous slides, the autopsy of that first young man who had the transplant and died of dehiscence. And I was trained that if a patient of yours dies and you go an autopsy, you go and you conduct that autopsy, or you are present there, because no one will have more interest in sorting out what happened than the surgeon who was involved. And I'm sure a number of us went down for that autopsy. But that picture that you showed earlier today of the atrial anastomosis, now nearly 3 weeks old, looking as if it had been done 3 hours ago, with not the slightest shred of healing. The two edges still held together by sutures, but wobbling with not a fibroblast in sight, was one of those observations that said, well, maybe it's a wound healing problem. And of course, having worked with Hermes Grillo, who was very interested in wound healing, and that was actually the early part of his career. He did a lot of work on tadpoles, and he was assigned by his chairman then to work on wound healing, and that's actually what got Dr. Grillo into tracheal surgery. So it was that observation, the opportunity of having a very good research fellow who's going to be there for a period of time, and that led to experiments, recognition that wound healing was a problem, that the wound healing was primarily not from rejection, but from the high doses of steroids required. The cyclosporin, which came along as an experimental drug, which made other transplants have better results, but I think made lung transplant possible in that era. Sandoz gave us some. We were able to use it in the laboratory to study wound healing and bronchial anastomotic healing. And the use of the omentum, which I learned from Dr. Grillo. He and many surgeons, as you well know, have used it because of its remarkable powers of bringing in new blood supply. And so
how did you put that all together and say, okay, now it's time to try it, and say, okay, Tom Hall, you're going to
Well,
have
actually,
this
before we do
opportunity?
that, can I say, like, there were some real major failures
yes.
that kind of occurred synchronous with the bronchial healing revascularization thing. There was the paraquat patient. There was a young woman with pulmonary hypertension who had a transplant and which we thought was perfect and died like minutes later or after arriving in the ICU. I mean, devastating setbacks before the Tom Hall situation.
Yes, that the gentleman who was flown up from Georgia with paraquat poisoning and irreversible damage to the lung, and who had a lung transplant, as you know, and was on ECMO for days, and on a ventilator for months. And then, of course, we didn't know how to look for rejection, and still, I don't know in retrospect how much of what happened to destroy his first lung was rejection, how much was the fact that we discovered when he got better and started moving, paraquat was stored in the muscles, and his blood level of paraquat in a delayed fashion went through the roof, and then his lung whited out. I still don't know what caused that. Yeah, and he died around Thanksgiving. We did him in August, and I think he died in I think American Thanksgiving, November. That was difficult. I think it sort of solidified the team, but it was very discouraging. And then there was, as you say, another failure, and that occurred between 78 and 83. I think probably it was
Right.
81, 82. So what happened was, by that time, the work that Dr. Lima and others did in the lab did show that wound healing was a problem, that we could avoid early steroids with the use of cyclosporin, that we could, in an animal canine model, produce reimplantation, which was our primary model, and some transplantation. We could go out several months and have a nicely healed bronchus in a fairly reproducible fashion. So that is what brought us to the point of doing it. I think in retrospect, the taking on of the paraquat was an opportunity, but perhaps in retrospect not the most judicious one. I think it did teach us something, though, which I've often thought about and I think was also very important, was who do you do? Choosing the right patient, because by that time there'd been, as I recall, about 44 failed lobar or lung transplants. And so who's next? Well, they were all deathbed rescue attempts. Patient on a ventilator, infected, renal failure, no hope of surviving, who would then be offered up for lung transplantation. But you're not going to get very far doing that kind of patient. There were too many things stacked against you. So we decided, as you know, to do pulmonary fibrosis. I do think that was, even though we now know those can be more difficult transplants, we felt that someone with pulmonary fibrosis who was on oxygen and desaturated when walking across the room predictably had less than a year, probably less than 6 months to live. And so by choosing patients who were not yet in hospital, not quite moribund, but who clearly had a very rough road ahead and a short life expectancy, we could offer to someone before they were on a ventilator, before they were infected. I think that was, in retrospect, one of the important decisions. We didn't know how long a donor lung could be preserved. So, as you recall, our strategy was we would not do a transplant unless we could fly or bring or transport the prospective donor to our institution, to the adjacent operating room, to shorten the ischemic time. And I think, again, that was probably a good idea. And the last was the ethics of it. And how do you decide? I mean, we're biased if you're particularly interested in carrying on lung transplant. How do you protect the patient from your enthusiasm if it's not appropriate? And as you'll recall, we went to the hospital. And again, great virtue of that system was that you didn't have to go to a payer or an insurance company to get permission. The hospital had its budget. It was a fixed budget. And they could decide how to use their funds. So we went to the hospital and asked for permission to do 5 lung transplants, and then stop and have an independent body review it. And we asked also for a committee. Elliot Phillipson, subsequently chairman of medicine, dean at one time, great pulmonologist, great clinician. Cam Gray, great pulmonologist. I think we had an ethicist. We set up a totally independent panel and said, these are the rules. We will transplant someone who has a condition which is going to prove fatal, who has no other alternative, who has no confounding other conditions which would jeopardize the outcome of a transplant. And only if there's unanimity in this committee that this is an appropriate patient would we go ahead. What you may not know, and I've heard, is I didn't want to talk to the patient before a decision was made. I found that in the first couple patients, I would look at x-rays, look at the reports, look at the pulmonary function, but I didn't talk to the patient. I didn't meet the patient. The committee approved a pulmonologist, Ron Grossman, or one of the other pulmonologists, was part of the selection process. It was a team effort. The committee decided that he met the criteria, and we would review x-rays, physiology, and decide yes or no. And then I would meet the patient. That happened just for the first few patients because it was sort of who shall live and who shall die. It was difficult to do, and we wanted to do it as objectively as possible. And soon got over that after a little experience. And so we said we want to do 5, and then we'll stop. And the hospital should review the data and decide whether we should proceed. Well, we were fortunate. Tom Hall was the first of that group. And as you know, he had pulmonary fibrosis, did a single lung. Again, the reason for pulmonary fibrosis was all you need is one good lung, and the other lung is so non-compliant that the ventilation will go to your transplant lung. Most of the blood flow will go to your transplant lung, so you could do a single lung, which is all we knew how to do in those days, or hoped we knew how to do. So, and then we decided a limited team. One anesthesiologist would do them all. It didn't make us popular. One group of nurses, as you recall, we assigned to it. We're doctors spread it around. And I think the environment, getting back to in Canada, and the cooperation, the team spirit, leadership that Griff and others exhibited, the willingness of colleagues to take on an assignment and play that role and support the team. I think it was a fairly unique environment, and I think that's what made it possible.
And we talked a little bit earlier and heard about Shumway and Wrights and Bart Griffith and heart-lung transplant. And so do you want to talk a little bit about morphing from single lung transplant into heart-lung transplants? There were some heart-lung transplants done, yes. And then morphing that into a...
It was interesting time. I think it was Bruce Wrights who came up. Someone from Stanford came up and gave a talk about heart-lung. The first successful one was done in 1981. And it was 2 years later, 83, that we did Tom Hall. It was exciting, But also the feeling in Stanford, I believe, and certainly by Dr. Shumway, is that lung transplant was not going to work. That the ability to biopsy the heart, and we heard about that at this ISHLT meeting today, the ability to biopsy the heart and diagnose cardiac rejection, and it was thought that that would accurately reflect lung rejection as well. We now know that that's not true, but there wasn't really any way of diagnosing lung rejection. And so the notion was that you shouldn't be doing lung transplantation, and I think we were lucky to sort of get it in under the wire. Otherwise, I think it would have been a long time. And also, I think, if you go back and look what we had in Toronto, surgical expertise, respiratory expertise, ICU care, ECMO, a history of interest. If we couldn't succeed, who's going to? I think if we hadn't been lucky and successful. So we did the single lungs. We did one that year. We did one a year later. We did one the following year. And those three all survived. Tom Hall died at 5.5 years, I think, of renal failure. And Monica Eisenheimer, who was the second one, died about 5 or 6 years. And the third one, all done in the months of November, he lived 11 or 12 years and died of a lymphoma or leukemia. But as you know, we were eager to do other diseases. And emphysema, which still is a major indication, was one of those conditions that we wanted. Cystic fibrosis. Those two, cystic fibrosis, obviously the idea of putting in one lung and leaving in a septic lung didn't make any sense. To take out one lung and leave an empty space in a bronchial stump in an immunosuppressed patient didn't make any sense. And as you know, in those days, it was widely believed, on the basis of successive failures with attempts at single lung for emphysema, that a single lung would not work because you had a VQ mismatch. The overly compliant native residual emphysema lung would get the lion's share of the ventilation, but the normal vascular resistance of the transplanted lung would get most of the blood flow. And it was widely believed, until the group in Paris subsequently showed that single lung was possible for emphysema, that you needed two lungs. And so heart lung. So Dr. Stuart Jameson, who had a brother in Toronto, was in Toronto and was good enough to come to the lab and help out and taught us how to do heart-lung transplants. As you remember, we used to call them lung-heart transplants. And did that for both pulmonary hypertension and for emphysema. I think we did a total of 7. The longest survivor was for pulmonary hypertension. She died just a couple of years ago, at about 23 years out. And then we realized that the heart wasn't essential. What we really needed is 2 lungs. And why should we waste a heart or put in a heart which is subject to its own problems? And that's when you came on the scene, Alec, and I think, as I recall, you and John Dark were working closely together to develop the ability to put in 2 lungs with the original version, technically very demanding. Cardiopulmonary bypass, single atrial anastomosis, tracheal anastomosis. The tracheal anastomosis didn't heal as well as they said it did with heart lungs because you don't have some of the collateral circulation. But that was the ushering in of the ability to transplant 2 lungs. And for those who might view this tape in the future, Dr. Patterson is a left-handed surgeon. He's a very good left-handed surgeon. But it was interesting days because I would be on one side of the table, the surgeon's side. Alec would be on the other side of the table. We did all those together. The surgeon's side, the surgeon's side. Each of us absolutely certain that we were the surgeon and the other was the assistant. But I don't have to tell you, Alec is a brilliant and wonderful technical surgeon, and responsible for a lot of the success that we had. And Alec and John developed this complicated but successful double lung transplant model. And that then made it possible to use donors, not sacrifice the heart or who didn't have a good heart to do it. And that sort of took me then through my Toronto phase. I left In 1988, we had done, what, 20, 30 transplants.
35, I think.
And I think we had a hospital survival of about 75% or something like that in those days. Still problems unsolved, airway and anastomotic problems among them, diagnosis of rejection. We used the Omentum initially and subsequently abandoned it. And so it was, again, I think it was a combination of interest, resources, cooperation, history of surgery there, talented individuals who were very willing to work together as a team and support a common effort. And I've often thought that if it hadn't been for that environment, I don't know whether it would have been successful, at least in that era.
So what happened? They threw you out, or you decided to leave on your own, go to Washington University?
Well, it's interesting, several things. We have 4 kids. My parents, my wife's parents, neither family of means, scrimped and saved and supported us to go to school in the U.S. Our kids could have had a wonderful education in Canada, and as you know, it was not as expensive. I couldn't afford to educate one of our kids in the States, and although I like to say I've never done anything for the economics, I did feel I would like to give my kids the opportunity of education in the States. So there was, number one, an economic issue. Number 2, as you recall, the system in Canada, maybe it's different now, was if you're a chairman of the department, it's a 5-year term and then a review, and 10 years and out. You can't succeed yourself. Now, I succeeded Griff as the divisional head. For divisional heads, it was 5 years in a review and 10 years and a search. That meant you could be a candidate, but there was going to be a full search of which you could be a candidate. And it's not a bad policy. So my 10 years also was, I was beginning to feel like I was coasting a little bit. So it was with great reluctance that I left that environment. Obviously been proud ever since, having gone back recently and seeing what Dr. Khashavji has created there. Is just absolutely phenomenal. It's exciting.
But I think you, as I remember back, you did look at a number of other opportunities. You ultimately became enthusiastic about Washington University, and then you developed another very successful lung transplant program there. Tell us a bit about that.
Yes, that's one of those, might be setbacks. You're right, I did have other opportunities. Dr. Jim Cox was head of the division, was very far-sighted. Again, both a brilliant surgeon and a wonderful innovator in terms of the fields of electrophysiology surgery, was willing and did to use the resources generated by cardiac surgery to support a unit in thoracic surgery in that division. Again, a unique opportunity with lots of opportunity and great support, and yet not really a structure of thoracic surgery there. A senior, wonderful thoracic surgeon there, but not an organized function. You don't get very often that chance in a career to go someplace where you are given encouragement, resources, great opportunity, and the chance to build something from the bottom up. It's one thing to go and succeed a successful individual, and that's great, and try to carry it to another level. But the opportunity to really start from the beginning, but with everything stacked in your favor. I was maybe overly eager to get a transplant program going, and we started that in 1988. And I accepted patients, some of whom were rejected in Toronto because they didn't meet the high standards that we had. I was eager to get a team trained, and we had some bad results. We had cystic fibrosis patients who were septic in hospital whom we transplanted. We hadn't done that before, and I think we had 1 or 2 deaths early on from sepsis, putting those people on cardiopulmonary bypass as we did then, and probably often do, but not always now. And that was a bad combination. Or individuals who had comorbid conditions and didn't have quite the team. And we did several transplants between July and December of that year. We did not have a success. Maybe we had one leave the hospital. And I was very discouraged. And I'll never forget Jim Cox, who was my boss then, head of the division. He said, "Joel, it's not a sprint, it's a marathon. You'll be all right." The next 40 patients lived, or 35, something like that. The other person, Mike Pask, whom you know, had been in Toronto. There was a cardiac surgeon there and had worked with us somewhat in Toronto. And he said, you just have to go back to doing things the way you did before. You're choosing patients who maybe are just too far gone. You're not giving you the opportunity to have success. And that was very helpful. But again, sort of encouragement of others and a team, as far as I was concerned, kept me going after some difficult times. And Mike had suggested, and as you know, there had been occasions when individuals had done separate bilateral transplants. One didn't work, they put in another, or there had been occasion, but it wasn't the routine. And Mike Pask said, look, you did so well, or better, with the single lung transplants. Why don't you just do one on either side? And as you know, that then became a programmatic portion of it, using the old-fashioned thoracosterotomy, avoiding the use of cardiopulmonary bypass, and it worked much better.
Oh, can I take it another direction? You seem to have unending energy. Sometimes it's quite amazing. What drives you?
It's interesting. I love what I do, but I always suspect when you see someone who's sort of hard driving that maybe they're trying to prove something. I never really felt, if I told you that I have an insecurity, you wouldn't believe it, and I've never felt that way at all, quite the contrary. But I wonder myself sometimes, what is it? Is it ego? Is it pride? Inquisitiveness. I always sort of ask a lot of questions and probably distinguished myself in class in elementary and junior high by asking too many questions and popping up, in a habit, as you know, that I haven't stopped. Ronald Belsey used to say, Cooper, remember the fish. When he keeps his mouth shut, he stays out of trouble. And I used to have a glass fish. I still have a glass fish on the mantelpiece, but I ignore it. I don't know. I do know that I've always loved what I do. I feel so grateful for the opportunity, and I guess I feel I don't want to waste it. I think that, and you two are in the same situation. We have a heritage. We have people on whose shoulders we stand. We didn't generate the resources that we have in the hospital, the nurses, the hospitals, the facilities, the things that allow us to work miracles. We owe that to other people. Maybe it's the fact that I come from a long Jewish tradition of doctors. My dad was an Orthodox rabbi, and it's surprising how many thoracic surgeons, Tom Todd, Norman Delarue, whom we know in Toronto, fathers were ministers. I've always sort of thought that maybe it teaches you the importance of service, but you're not willing to make that much sacrifice as they did. So I don't know. All I know is that I have felt for many, many years, probably since the time I was 25 or 30, that if I died tomorrow, I would have had a wonderful life. I just have been just so lucky to have so much support, parental support and colleague support. And also, yeah.
Well, I'd say you also have had strong family support. Like there's what's the famous saying that behind every successful man there's an astonished woman. And, so what you should we appreciate, both of us certainly appreciate the support of family, or tell us about your immediate family.
Right. Well, Dad, I mentioned to you, and my mom, both very supportive of my two brothers and and myself. My dad, who at a time when my brother and I were in college at Harvard, I think he was earning a sum total of $12,000 a year before taxes. Each of us was spending $4,000 a year. He went without, didn't want us to work in college, said, your job is to study. And all I ask is do the best you can. That's, So there was tremendous support and appreciation. And then my wife, Janet. I've often told the story. Janet and I have now been married. It's coming up on 47 years. We were married when I was, and we were married in 1963 when I was a third-year student in medical school, and she taught. Her mother taught school. Her father taught school. My mother taught school. Went back, and after we went to college, and in those days, you worked every other night, every other weekend. So when I was a resident at the Mass General, an intern resident, my wife would come down with a sandwich, and she would sit in a car in front of the hospital on Fruit Street. And I'd say, oh, okay, I'll be out at 7 o'clock, and I'll sit for it, because every other night, every other weekend. Well, you know me, and I know you. 7 o'clock becomes 9 o'clock. Never complained. She'd be there 2 hours, just so we could spend 5 or 10 minutes together. And I've been very lucky to be able to have a family and that kind of support. It's sort of old-fashioned, but it certainly allowed me to if you don't have a happy life at home, it's very difficult to be productive in your work, and our spouses don't get the kind of recognition that we do from it. So that certainly has been extremely important. And the kids as well. I don't know whether they resent or not the fact that I was never there, never had dinner with them, etc. They've never said that they did. I like to feel that if you're happy in your work, even if it takes you away, it has some beneficial effect on your family life. And the fact that 2 of our 4 sons went into medicine and work as harder than I ever did, for what I think are the right reasons, is maybe a reflection on that.
Joel, you're a very tough taskmaster. You're tough on yourself. You're tough on the people around you. And yet you have, certainly Alec and I are a product of your taskmaster. And you've stimulated many students to get excited about the work like you do, to strive to achieve 100%. Like, how do you balance that between driving people crazy versus trying to get the best out of them?
Yeah, that's...
You don't always balance it, that's for sure.
No, I certainly don't. And I must say, the fact that my family and my colleagues tolerated me, and, with that, you're right. I know that the absence of criticism on my part is taken as the highest praise. And it's not a great habit. I'd like to think that a saving grace to a certain extent is that I try not to take myself that serious. I think that's fatal. You can be serious and set high standards and goals, and as you say, I try to set them for myself. It is very exciting, though, to see people's careers come along, and to see people develop and reach their potential, and nothing makes me happier. You've both heard me quote repeatedly at the annual dinners for residents a saying that my father told me was in the rabbinic teachings, that there are only 2 people in this world that we are never jealous of, and that is our children and our pupils. We want them to be better, but in a way that's probably a bit selfish, because it's a reflection on ourselves. So there's some ego in that as well. But the notion of seeing people come along and develop and achieve is very exciting. I'll tell you who I don't think I am tough on, and that is people whom I haven't had high expectations of. If a person is beyond their capabilities, or really is not the kind of person who can be motivated, I've always tried not to put pressure on someone like that to acknowledge it. And as I've gotten older, I have a hard enough time knowing if what I do is right, much less judging somebody else for what they do. But I've always, I don't know, I'm just lucky. I've been able to get by with very little sleep. I have had a high energy level. I always used to think that I was maybe hyperthyroid, but never wanted to be tested. In case, what would I do?
If they change
Yeah,
that.
I actually was once tested, and I'm not hyperthyroid. But I think we're all, I mean, you two are great achievers, contributed a great deal. We do it in different ways, but you have the same standards that I do.
Well, this has been a terrific opportunity to talk, Joel. We've covered the entire waterfront of an outstanding career and many wonderful accomplishments. It's a privilege for the ISHLT to have this on record. And
well, it's nice to be here discussing with two people who helped make it all possible. So thank you.